A very good morning to all.
Good morning, sir.
I think the mediastinum and all they are clear to you by now. The mediastinum, isn't it? The
Yes.
trachea is done. The tracheobronchial tree. I mean, not the trachea. The tracheobronchial tree, the bronchopulmonary segments, all those things are done. Today we'll be discussing about the trachea, esophagus, and the thymus in whatever we see it, which is present in the thoracic cavity. Okay. Now we'll start with the trachea. Now here you already, this is a picture I think from your higher secondary books where you can see there is a nasal cavity, the oral cavity. Okay, the nasal cavity stays up, the oral cavity down, separated by the palates. Then the nasal cavity, from there is an area known as the nasopharynx, the oropharynx. Then from there, it the nasal cavity, the air passes to the anterior part, while the bolus of food will pass to the posterior part, isn't it? In the anterior part, this area consists of some cartilages, starting from the epiglottis, the thyroid cartilage, the cricoid cartilage. These are all known as the laryngeal cartilages, and this area is thus known as the larynx. We have the vocal cords over here. Posteriorly, this continues as a part of pharynx. The whole of it is pharynx, which consists of nasopharynx, oropharynx, and the pharynx, which lies just posterior to the larynx. So you've got a larynx in front and pharynx posteriorly, isn't it? Now this larynx, which are lying in front, you can relate it in surface anatomy. Now also you can just see your cartilages in the neck, which is known as the thyroid cartilage, or the, in common words, in common terms, the Adam's apple. And below you can see the the cricoid cartilage, and down there the trachea starts, isn't it? And posteriorly the laryngopharynx there. After that, after the laryngopharynx, esophagus will start. Okay, so larynx continues as trachea, the pharynx continues as the esophagus. Okay, now so the trachea lies in front, the esophagus lies in back, and now this transition happens in the C6 vertebra. See, from till here, till the cricoid cartilage, it is the larynx, and just posterior to it, it is still the pharynx. Now, from cricoid cartilage, which is at the level of 1, 2, 3, 4, 5, 6, C6, cervical 6 vertebra, then we call it as trachea. So, at the C6 level, the larynx continues as the trachea, and the pharynx at the same C6 level continues as the esophagus, isn't it? Now, how to calculate this cervical vertebra? So, this is the, anyone, what is this? The small, okay, a piece of vertebra which you can see over here. What is this one? Anyone? Can you see this? What is this one? Anyone? Which number vertebra? So, it is the C1. Okay, the C1 lies, there is a ring of C1 which lies like that. So, in cross section, it just appears as it's having only the anterior portion. So this is the C1, which is also known as the atlas. Now over this axis, the atlas will move. Okay, so that's why it's known as the axis. So axis is C2. So atlas or C1, axis C2, C3, C4, C5, C6. So at this level, the transition happens. Okay.
Yes, sir.
So if there is any doubt, I'll give you time. You can ask. Okay. When we start with the trachea, now it consists of both the cartilage as well as membranes as well as muscles. So it should be ideally membrano-musculocartilaginous. Okay, I've written membrano-cartilaginous as given in the books, but actually it consists of these. See, this is the cricoid cartilage, this is the thyroid cartilage, this is the membrane in between them, which is known as the cricothyroid membrane. Now this is something which comes under the larynx. We will have a separate class for this. Below that, this level will be C6. So at C6, the trachea will start. Okay, and it consists of the cartilaginous C-shaped cartilage. These are cartilages which are C-shaped. Okay, so they may be continuous or they may branch like that. And since they are C-shaped like that, okay, so posteriorly there is a gap, and this gap is filled by a smooth muscle which is known as the trachealis muscle. The trachealis muscle. Now here it begins at C6, as I have already told you. C6, it's a membrano-cartilaginous tube, also consists of a muscular part, that is the trachealis muscle. This is a smooth muscle. It it comes down. The length is about 10 to 11 centimeter. Okay, 10 to 11 centimeter, and it bifurcates at the level of T4, thoracic 4 vertebra. And in adults, in cadavers, you see it bifurcates at T4, but in standing position and in live person, usually it can go up to T6 level. Usually we say that it bifurcates at T4 level. What is the length? 10 to 11 centimeter. Okay. So here, if you see this picture, you can see the sternum. Okay. There is somewhere, this is the manubrium sterni, this is the body of the sternum, somewhere down there will be the Seifert process. Now, in the manubrium sterni above, there will be the first rib with its costal cartilage. The second one will attach both to the body and the manubrium sterni, and this is an area where there is an angulation of the sternum, and this area is known as the sternal angle, isn't it? Now, this sternal angle is having certain importance. It corresponds posteriorly to the T4, and this is the level where the bifurcation of trachea this happens. Okay, this is the level. So from sternal angle there is the bifurcation of trachea, but in standing position the bifurcation may extend in live individual till the T6, somewhere here. Okay, any other importances of sternal angle since the mediastinum is done? Anyone? Any importance of sternal angle? Yes, anyone? Sternal angle importance? Yes.
It divides mediastinum into superior and inferior mediastinum.
Very nice. Anything? Because we'll be having a clear picture over here. Anything else? So the sternal angle, see here, the second rib attaches here. Okay, corresponds to T4. The part above is the superior mediastinum. The part below is the inferior mediastinum, which again can be divided into three. Trachea bifurcates here. Okay, the trachea bifurcates here. There is ascending aorta, starting of the ascending aorta and ending of the descending aorta. Ending of the starting ascending aorta and starting of the descending aorta. This line. So the arch lies above it. The arch of aorta, it lies above it. So these are some importances of sternal angle. Now, why am I saying all this? Why you should be knowing all this? Because you'll see the X-rays, you will see the CTs, you will see the MRIs, then you will have to identify each and everything. Now, once you are done and you complete MBBS, I think more than us, you'll be dealing with the CTs and the MRIs in near future. Many more things will come. Now, then over there, you will have to know the structures by looking into it. And without the anatomy, it will be very difficult for you to understand. So, this is more or less here you should be knowing about the relations, which becomes very important. Okay, in the thorax the relations of the different structures are very important because you are looking into the chest X-ray, you are seeing the CT scans, you are seeing the MRIs, isn't it? Of various reasons they are being done, and nowadays the most commonly done is the CT scan, isn't it? Why we are doing the CT scan very regularly now? For what? Any disease? Any pandemic going on? We are doing the CT scan for? सो गया सब लोग? COVID-19. So in COVID-19 में CT में क्या दिख रहा है? There are patchy consolidations. There is pneumonia, viral pneumonia, isn't it? So we are having different scores. So they are, you know about the CT score? There are different lobes in the lungs, isn't it? How many lobes in the lungs? Left lung, how many lobes? फटाफट बोलो, there is no. Left lung में कितना लोब है? Yes? Two lobes. And right lung?
Two, sir.
Right lung, three lobes. Now, each of the lobes are divided into certain zones. Okay, each of these lobes are given points, 5 points. So, total lobes kitna ho gaya? 5. So, 5 into 5, 25. Now, we are doing a CT score in COVID. We are doing a CT score. So, if the CT score is 25, that means all the components, all the areas of these 5 lobes are affected. So that is a bad prognostic. Okay, there is a bad prognostic indicator for the outcome of the COVID-19. So like that, you will be seeing more of this, more than us in fact. So you should be very clear about the anatomy and the relations in the thoracic region. Now you see the lumen of this trachea is about 12 millimeter in adult, and in case of children it is 3 millimeter. Now we should be concerned about the lumen because we are again for doing it for endotracheal intubation. In case of adults, different sizes are there. In case of children, we should be knowing about the sizes as per the age. Okay, or because it may cause trauma if you don't know the size and you are inserting something which is much larger, it may cause trauma. So in children it is 3 millimeter till third year, then it increases 1 millimeter per year till 12th year. So after 12th year it is about the adult size. Okay, so that is about the lumen of the trachea. Now this trachea at T4 divides into two. Okay, these are right and left bronchi, or the right and left principal or the main bronchus. Here you see this is the left, this is the right. Now the right bronchus is more in, okay, the angle of the trachea and the right bronchus is less. It is more in line with the trachea, whereas the left is going a little oblique, okay, a little more vertical than the right, because the trachea is towards more towards the right. Okay, during its termination, during its bifurcation, it is more towards the right. Now you see any foreign body which lodges, which suppose a foreign body is there, it lodges in the pharynx, the oropharynx, the laryngopharynx, then it goes to the trachea. Mostly the coins which are being, okay, sometimes the coin are being eaten up by the students. The chances of it getting to the right side is more because the angulation here is less. It's in the same, almost in the same alignment with the trachea. So you should be looking for a coin which is small and a child ingests it and it goes to the, mostly the chances of getting it into the right bronchi is more. Now this tracheobronchial tree, I think it's already been done, so we won't be discussing it in details. There are these bronchopulmonary segments, 10 on each side, which is having very significance clinically. What are bronchopulmonary segments? Anyone? What are bronchopulmonary segments? How can you define? Just not the, what is the idea behind the bronchopulmonary segments? Anyone? Can you hear me?
Yes, sir.
You can hear me. Okay. What are bronchopulmonary segments? So these are the segments which are being aerated by individual. See, these are the tertiary bronchus. Okay. These are the tertiary bronchus which are ultimately going and aerating the individual segments of the lungs. ठीक है, चलो, we will be discussing it later. Now we know that the trachea divides, starts at C6 level, goes down, T4, it bifurcates. Okay, the length is 10 to 11, the lumen is 10 mm, in children 3 mm, increases 1 mm each year till 12 year, and the right bronchus is more in alignment with the trachea, and it's having C-shaped cartilages, so there is a gap posteriorly. Okay, now posterior to it you can see a muscle over here, a tube over here. In fact, now this, what is this tube? Anyone? Posterior to it there is another tube. What is that tube? This tube?
Esophagus.
Esophagus. So
Esophagus.
yeah, esophagus. Now this is the trachealis muscle. Now these cartilages are incomplete, isn't it? So the first thing, why there is a need of a cartilage in trachea? Anyone? Any idea why there is a need for a cartilage in trachea? Why it couldn't be just a muscle? Why there is a need of the cartilage here? Anyone? Anyone? Any idea?
to, to prevent collapse while breathing.
Because while breathing, yes, very good. Because while breathing, while inspiration, there is a negative pressure being created inside the trachea, isn't it? So if it would have been only a muscle, a smooth muscle, that is not, it won't be able to maintain the lumen. It will collapse, isn't it? And plus it is C-shaped. Okay, it's not complete. Now, why it's not complete? The second question. Why it's not complete? What if it would have been complete? More easier, won't get collapsed, more better, isn't it? Why it's incomplete? Anyone? Any idea? Why there is a gap posteriorly and there is a esophagus posteriorly? Now, why there is a gap for the esophagus posteriorly? Why? Any idea? Any logic idea? Any logic behind that? See, in the esophagus, you're taking the food going down there. Now, if it would have been ज़्यादा खाना खा लिया, कुछ ले लिया, बड़ा सा केला खा लिया, okay. The bolus of food, if it would have been the cartilages, complete cartilages, the bolus of food won't go down, isn't it? Because here the bolus, the esophagus enlarges as the food goes down, so there will be obstruction if there is a cartilage down there in posterior aspect, isn't it? So movement of the passage of the food through the esophagus will be a little difficult, isn't it? You have to chew or you have to grind it in the mixer, then only you can take it, isn't it? So that is why it has been given as incomplete C-shaped cartilages which are made up of hyaline. Okay, so it's the same thing. We are seeing what is from the sagittal view, or you can say the lateral view, all the mediastinum. Now here you can see the mediastinum, yahan se upar se you can draw a line till T1, isn't it? Now from sternal angle till T4 you can write, so this becomes the superior mediastinum, below that becomes the inferior mediastinum till the diaphragm down below. Now again the inferior can be divided into an anterior, here this is the anterior, just anterior to the heart, then the pericardium with the heart occupies the middle mediastinum, and rest of these vessels and all these tubes and the structures lying posteriorly comes under the posterior mediastinum, isn't it? So I have given more of pictures in my class for today so that you can at least visualize things, and once you visualized it, more easier to remember. Now let us see, as I have told you, it's very important for you to know the different relations, okay, different relations of the trachea. As the trachea moves down, there are यहाँ पे first rib रहेगा, इसके ऊपर हाँ many structures are there. So let's just see. So there are two parts of the trachea. This part which lies in the neck. This part lies in the neck, which you can see from the outside neck, and then the part which lies in the thorax. How it passes, let's see. So in the neck, so this is the neck. You can see the clavicle, the manubrium sterni, and these are some muscles over here. These muscles are running from the sternum till the mastoid process. So this is known as the sternocleidomastoid. And there are some muscles. So this is the sternocleidomastoid, a muscle which is running from the sternum to the bone which is known as the hyoid bone. So this is sternohyoid. Okay, this is sternohyoid. Okay, another bone which is running from another muscle which is running from the sternum till a gland, okay, which occupies the anterior and the sides of the trachea, and this is known as the thyroid gland. So this muscle is known as the sternothyroid. Okay, so when you move, when you are going to dissect the body, even you can this is the sternum and this is the known as the jugular notch, isn't it? So if you can palpate right now, you can palpate your trachea just above it. So the tube which you are palpating just above the suprasternal notch, try to do that now. Okay, just try to palpate the trachea just above the supra. So this tube is the trachea just above the suprasternal notch. And while approaching this area, in various reasons you have to approach this area. In emergency medicine, whenever you are in village, sometimes there can be an obstruction. So you may have to approach this area. It's very important. So you are cutting the skin, the superficial fascia, the cervical fascia or the deep fascia of the neck. Okay, then you will be getting the first thing over there. This is the jugular venous arch. Okay, the jugular venous arch. See the jugular venous arch. This is the internal jugular, the external jugular vein. Okay, and this is known, these two are the anterior jugular veins. So these are the anterior jugular veins. Okay, now these anterior jugular veins are being connected through the jugular venous arch. Now these veins lie within the superficial fascia. So veins are superficial to the deep fascia, isn't it? The superficial. So this is a superficial vein. So just above the cervical fascia or the deep fascia it will lie. So jugulus venous arch is our first relation. After that you will be getting the sternothyroid, the sternohyoid. This muscle is the sternothyroid. Then you are getting, just go above, the isthmus of the thyroid. See, the thyroid gland is having two lobes and connected in between by an area which is known as the isthmus, a portion which is known as the isthmus. Now this isthmus lie against, so this is the first tracheal ring, then second, third, like that. So against second, third and fourth tracheal rings. Okay, so this is the isthmus of the thyroid. Now along with the isthmus above there is the superior thyroid artery. On either side there is anastomosis. Okay, jugular venous arch, sternohyoid, sternothyroid, okay, isthmus of thyroid, the anastomosis of an artery which supplies the thyroid, which is known as the superior thyroid artery. There is anastomosis above. Okay, now when you are going from superficial to deep, first see this, you are getting the skin. Can you see my slides over here? You are
Yes,
there?
sir.
Yeah.
Yeah.
So this is the skin. Okay, the yellow thing is the superficial fascia. Okay, then the green thing, see, in neck it's not that simple because there are so many structures in the neck. The deep fascia is divided into three layers. First is the investing layer, second is the pretracheal layer, prevertebral layer, and from there itself they are forming a sheath which is known as the carotid sheath. Now there are one, two, three layers. Of what? Of the deep fascia in the neck. So the one layer, which is the first layer, which is known as the investing layer, the name is investing. So what it does, it is investing and encircling all around the neck to form a sort of sleeve. Okay, form a sort of socks all around the neck to keep the muscles in position. The green one is the investing layer. So when you go from skin side, the first you are getting the investing layer. Now these veins, the jugular veins and all these veins, okay, you will be getting in the superficial fascia with a muscle which is known as the platysma. Okay, in the center, of course, the platysma is absent anyway. So after this investing layer, you are getting another layer, the modification of the deep fascia itself, which is known as the pretracheal layer. The what is this color? The purple or the violet one. This is the pretracheal layer. Okay, after that you will be getting the trachea. Okay, and the isthmus of the thyroid. Above the isthmus, the superior thyroid artery. Before that, all these muscles, sternohyoid, sternothyroid. Okay, above the thyroid, the superior thyroid artery anastomosis. Okay, plus along with the jugular venous arch, see, I have just tried to draw. What is this vein? I have tried to draw it as a continuation. What is this vein? Anyone? What is this vein? Just going posterior to the clavicle, and above the first rib it will go. What is this vein? And this artery. Yes, very nice. So the subclavian vein. So there is a vein which is draining into the subclavian vein. I have drawn it by myself, so I don't know how much it is clear. This is the inferior thyroid vein. So it is draining the thyroid. On either side it will be there. So once it drains the thyroid, it will uh, open into the subclavian veins. So this is also one of the relations. Okay, now when you talk about the veins in the superficial veins, these are the jugular venous arch, the inferior thyroid vein. Okay, so these are all the relations of the thyroid in the anterior part. Now here, sometimes you might have to do a procedure which is known as the tracheostomy. Okay, suppose there is an obstruction in the upper airway. Okay, there is obstruction over here. There is some malignancy in the larynx so that the air cannot be sucked in through the trachea. Now here you have to open the trachea by giving an incision and inserting a tube. Now that is known as the tracheostomy. Now while doing tracheostomy, you should be knowing what are the structures I'll be encountering. So this is a procedure which a simple MBBS should be knowing. Okay, so you should be knowing all this anatomy. So is this part clear, the anti-relation of the trachea and the neck?
Yes,
Yes?
sir.
Okay, so first what we are getting, skin. superficial fascia, the veins, jugular venous arch. Okay, then we are getting the investing layer. Okay, then just beneath the investing layer, these muscles, sternoid, sternothyroid. Then we are getting the pretracheal layer. We are getting the pretracheal layer. After that, all these isthmus of thyroid against second, third, and fourth tracheal cartilages, the artery, the inferior thyroid vein. Okay, so these are some relations, anti-relations of the trachea. Now just see what are the posterior relations. So I have drawn so many, I have shown so many things over here. Now in the posterior, this is the trachea. ये था first strip. Okay, first strip was going somewhere here. So ideally there should have been the manubrium. Here the body of the sternum. So just posterior is what? You all know this is the esophagus. Okay, the esophagus. You see, just this is the trachea. At sternal angle it will divide. This is the esophagus. This is the esophagus, and these two red are, I have just make them as red arrows. These are the recurrent laryngeal nerves which lies, this is the trachea, this is the esophagus, and the groove between them, the gap between them is known as the tracheo-esophageal groove. So the recurrent laryngeal nerve will lie like this, okay, on either side. So recurrent laryngeal nerve ये है, this one on the left side, this one on the right side, okay. So these won't lie by the side, these are lying posterior to it, okay, just in front of the esophagus. So these are the posterior relations. Here also you can see the esophagus lying posterior to it, and in these groove there will be the nerve, the recurrent laryngeal nerves, okay. What are there laterally? Laterally you see the lobes, the actual lobes, the lateral lobes of the thyroid gland. This is the isthmus, which is the relations in front, okay. This is the isthmus of the trachea. By the side there is the lobes of the trachea. And what are these vessels by the side? These are the common carotid artery. We are talking about the relations of trachea in the neck. So the common carotid arteries on the either sides, okay. So as ये है arch of aorta से यहाँ brachiocephalic trunk निकलेगा, ये देखो brachiocephalic trunk on the right side we divide into subclavian and common carotid. Again on the right left side, common carotid individually, subclavian individually, isn't it? So on either side of the trachea there is one, there is two, both the common carotids. These are the lateral relations, the common carotids and the lobes of the thyroid gland. Till here is it okay?
Yes, sir.
Okay, chalo, we'll move forward. Now we'll see what are the relations of the trachea in the thorax. So this picture is a little bit, it seems it's very complicated, but it's not. Just I have drawn the impressions for the manubrium sterni. So in front, what will be there in the thorax? The manubrium sterni. Because here, near the somewhere in the sternal angle, which corresponds to the T4, the trachea already bifurcates. Now we won't be calling it as trachea. यहाँ पे कहीं पे the trachea will end. Okay. So the first relation, the manubrium sterni, not the body of the sternum, because by the time it reaches the body of the sternum, it will bifurcate, isn't it? Then इसके पहले क्या देखा था? Pretracheal fascia. So we have already seen the pretracheal fascia, this one. Okay, pretracheal fascia. Then next is the thymus gland. You see, this is the thymus gland, just posterior to the manubrium sterni. There is the thymus gland. After that, you will get the other structures. Okay, so manubrium sterni, the thymus gland, then the pretracheal fascia. Okay, then you can see the left brachiocephalic, here it is more clear, the left brachiocephalic vein, which is coming in relation with the manubrium sterni. Mostly it stays in the upper half. Okay, the left brachiocephalic vein. See, this is the internal jugular draining the head and neck on either side. This is the left subclavian. This is the left subclavian. Both the subclavian and the internal jugular forms the brachiocephalix. Now since it has to open on the left side, the venous drainage to make the superior vena cava, the left brachiocephalic is elongated. So that's why it has to travel a long distance, okay, to form the superior vena cava, which will drain into the right atrium. So this is the left brachiocephalic vein which comes in front of the trachea, okay, in the thorax. Then the brachiocephalic trunk, posterior to it, you see there is one. Ye hai arch of aorta, isn't it? This is the arch of aorta, okay. So the arch of aorta at the bifurcation of trachea lies in front of the trachea. This is the trachea, somewhere down it will bifurcate. So near the bifurcation, the arch of aorta, with a plexus which is known as the cardiac plexus. Just above the bifurcation, the brachiocephalic trunk and the left common carotid artery. So these are the relations of the trachea in the thorax. Is it clear? Shall I need to repeat anything?
Sir, please repeat this part.
So anyway, so you see the trachea here. Okay, we will just see here in this picture. This is the trachea. Okay, somewhere here it will bifurcate. This is bifurcating, isn't it? So what are the things? So we are not talking about the structure which in the neck. We are talking this. This is the thorax. This is the neck. This is the thorax. This is the neck. This is the thorax. So in the thorax, manubrium sternum. Okay. Just posterior to the manubrium sternum, what we have seen earlier, the pretracheal fascia. Okay. Just posterior to it, in the thorax, we are talking in the thorax, this yellow thing having two lobes. This is the thymus gland. Okay. Just posterior to the thymus gland, the brachiocephalic, which side? The left side. See, we are talking about this, the trachea, which is going like that. So the left brachiocephalic vein. Then arteries. This is the trachea. The just posterior to the left brachiocephalic vein, the brachiocephalic trunk, the artery which divides into two. So brachiocephalic trunk. The left common carotid, isn't it? The left common carotid and the arch at the bifurcation. So these are the relations. So you can see the trachea, posteriorly esophagus. So these, the left brachiocephalic यहाँ पे मिल रहा है in front, ठीक है? यहाँ पे the brachiocephalic trunk only will come in front of it, okay, and lower down the aortic arch, okay. Now in children, what happens? The left brachiocephalic vein and the summit of aorta. See here, this aorta, okay, this vein, they are lying in this part. Since this is the manubrium sternum, this part is the thorax. But in children, the aorta and this vein will lie above here. So it comes in front and as anterior relations of the trachea in the neck. So in fact, you can say that somewhere here they will come in the neck. Aorta might come like that. Brachiocephalic vein might come like this, just above the manubrium sternum in the suprasternal part here. So performing a tracheostomy in children below, I guess, 11 years, okay, it is a contraindication. You do not perform tracheostomy in children before you visualize those structures, because you can puncture the brachiocephalics and the arch of the aorta, causing profuse bleeding, and the child may die. Okay, so that's why in your hands, okay, there is whether the patient will live or not. So you should be knowing all the anatomy over here. Posterior relations, nothing much. Esophagus, okay, and left recurrent laryngeal nerve. We are talking about the thorax, this part. Okay, so trachea may the left. So above in the neck, the trachea may be related to both the recurrent laryngeal nerves in the neck. But here, since the right recurrent laryngeal nerve will hook around the brachiocephalic trunk, the left one hooks around the arch of aorta. Okay, so in the thoracic part of the trachea, the posterior relation is only the left recurrent laryngeal nerve, because the right one has already gone up, and this is related only to the cervical part of the trachea. Okay, this is the cervical part जहाँ पे काट दिया था, इसके पीछे दोनों recurrent laryngeal nerve दिख जाएगा in the neck, but in the thorax only you can see the left recurrent laryngeal nerve. It is known as recurrent. It is a branch from the vagus moving on either side. The vagus is the 10th cranial nerve. From the vagus, it goes up, and that's why it's known as recurrent laryngeal nerve. So the vagus nerve moves up like that, and the branch from it is known as the recurrent laryngeal nerve. In the right side, it winds around the subclavian, so it's only come into relation with the trachea in the neck part, in the posterior relation. But in the left side, it goes down, I mean the vagus, it goes down, then it gives the recurrent laryngeal nerve which winds around the arch of aorta. That's why it comes into the picture in the thoracic relations of the trachea. Okay, so in the thoracic part, the esophagus and the left recurrent laryngeal nerve is the relation. Now the right and left side. Okay, this is the trachea. Okay, this nerve is the right vagus nerve. So it's the relation on the right side. What else? Arch of azygous vein. Okay, so vagus nerve, arch of azygous vein. These are the relations, and plus यहाँ पे क्या रहेगा? The pleura. Okay, left side में क्या रहेगा? Again you see the trachea is moving there. You can just see the esophagus. So left side में the trachea is somewhere here on the other side. So you are finding the, what is this? The subclavian artery. Okay, the subclavian artery. Okay, the common carotid artery. Okay, the arch of aorta. So these will be the relations of the left side. Okay, so if you see this picture, it becomes quite easy, the relations of the right and the left side. Okay, so till here it is clear. Is it clear?
Yes, sir.
When you go in the wards, when you go in the OT, if you get MCH in CTVS, okay, if you are a radiologist, each and everything over here is very, very, very much needed, very important. The relations over here, very important. Okay, any cousin of you, any patient of you coming and asking you about the CT, then you don't have to go and read the Choracea. Okay, over there. So already we have talked about the C-shaped cartilaginous rings, which are hyaline cartilage. They are 16 to 20 in number, about 16 to 20 in number. And the last ring over here, which is triangular in shape, okay, so that it holds both the bronchuses, is known as the carina. Okay, this is the carina, this is the angle where the trachea bifurcates. Okay, and this becomes important while you are doing a bronchoscopy. Now in a bronchoscope, okay, a scope is inserted with a camera. In the camera, you can see the right and left bronchus. Okay, and this is an area, this is corresponding to the carina. So this is the carina. You can see the, okay, both the bronchuses, and this becomes important while you are entering a scope inside. You are seeing any pathology inside. Okay, bronchoscopy. Okay, what is the epithelium? Now, also one more thing, this carina over here is the last area of defense, they say, because the epithelium over here is very sensitive, the nerves over here are very sensitive, and this is the last part where there is the cuff reflex. Whatever is inserted inside a foreign body gets inserted. This is the last area and the most sensitive area which is there for the foreign body, and that foreign body is being attempted to taken out by the body by the cuff reflex. Okay, the epithelium is ciliated, pseudo-stratified ciliated squamous. Okay, epithelium, and there are so many goblet cells along with it. These goblet cells, they are secreting the mucus. Okay, the cilia are there, so there is the mucus with the cilia. Any foreign particles, they will get attached themselves to the mucus, and the cilia will beat it up, okay, which is known as ciliary current, and that part is known as the mucociliary barrier. About the blood supply, see, this is the trachea, so the inferior thyroid artery is giving a branch. The internal thoracic artery is giving a branch. Now these branches are supplying the trachea as segmental arteries, as a linear segmental arteries. Okay, the supreme intercostal arteries is also giving some branch, and there are the bronchial arteries, superior and middle. Okay, so inferior thyroid, internal thoracic, supreme intercostal, and these bronchial arteries are the arteries which are supplying the trachea. Now, venous drainage, the inferior thyroid vein. You can see these veins are the inferior thyroid vein which are draining into the left brachiocephalic This was in relation which part of the trachea? The left brachiocephalic vein. Anyone? Which part of the trachea and what relation? Thoracic, thoracic part, anterior relation, isn't it? So from there, the inferior thyroid veins will come and they will, while they come up and go to, while they are going down to get drained, they are also draining the trachea along with the thyroid. The lymph nodes are pre and paratracheal lymph nodes. Now, just in front of the trachea are the pretracheal, by the side are the paratracheal. So here in an X-ray you can see these lymph nodes. You won't be able to see in PA view, but you can see these lymph nodes. I don't know the cause, but they may get enlarged in many causes, in chronic illness, in malignancy. Okay, so these are the paratracheal lymph nodes. You can see the paratracheal lymph nodes. Parasympathetic part by vagus and recurrent laryngeal nerve, which are secretomotor, and sympathetic by T1 to T5. So what will be the role of parasympathetic in trachea? Any idea? Unsympathetic. Sympathetic will, so we need the sympathetic during emergencies. So sympathetic will
dilate.
very good. Chalo, I'll move up. So we were seeing all these anterior relations of the trachea. ठीक है, ये सब देख रहे थे हम लोग. Why we are seeing? Because it is very important for us to know there is a procedure which is known as tracheostomy. Now the tracheostomy is done in many causes. There is an upper airway obstruction. Okay, suppose the patient is being not able to breathe by his normally. Okay, there may be sometimes a malignancy above. There may be paralysis of the area. Okay, so here a procedure where the trachea in the part of the neck is there is a hole being created over here, incision and a tube inserted. So that is known as the tracheostomy. So it may be cricothyroidectomy, it may be open tracheostomy, or it may be through the skin done, which is known as percutaneous tracheostomy. So it may be high if it involves the first tracheal cartilage, if middle, second, third, fourth. If you do something here, this is middle. If you do something here, this is low. Okay, so what you are doing here is that this part in between the two sternocleidomastoids and all those muscles which are known as the stripe muscles, sternohyoid, sternothyroid. So this part where you can feel your trachea is the most safest place, which is known as the triangular space of neck. Okay, for the tracheostomy. So there are very less chances that you will be injuring any vessel. Of course, there are superficial veins. Okay, while you are doing tracheostomy from here. So we'll just see what we have discussed, the cricothyroidectomy. So there is a in between the thyroid cartilage and the cricoid cartilage, there is a membrane which is known as the cricothyroid. Okay, and the muscle will be lying above. Now what you do here, the first patient is in supine position and neck extended. You see the thyroid cartilage, the Adam's apple. You feel for the cricoid cartilage, then you feel for an area in between them where there should be the membrane between the thyroid and the cricoid. After that, you give an incision like that. 1 centimeter vertical incision through the skin and the subcutaneous tissue. There are chances of bleeding. Then you have to cure the bleeding. Then you are using a hemostat. उसको पकड़ने के लिए you just through the hemostat secure the bleeding. Okay, another horizontal incision you give, and you give an incision to the cricothyroid membrane. You are puncturing that membrane and you are creating an opening over there. Okay, now through that opening you are inserting this tube. This is the tracheostomy tube. Okay, and you are inserting another bag and mask ventilation for the patient. It is usually a temporary tracheostomy. Okay, so this is, I'm just showing you the procedure to know what are the clinical implications of the anterior relations of the trachea. Okay, we are not just studying it just like that. There are many implications for it which will be used by you later on. These are just a picture. I think we know it, all those things by now. Now let us come to the esophagus. Is it clear, the trachea part by now? Okay, there is very less time. Now if you see the esophagus, it is a muscular canal which is extending from the pharynx to the stomach, which we have already seen in our previous picture. The pharynx, it is continuous as a muscular part. The esophagus, okay, a muscular tube. Now the length is about 25 centimeter. So it starts from where? In the C6, the tracheal cartilage, this is the cricoid cartilage corresponding to the C6 vertebra. From there, same thing for the esophagus, same thing for the trachea. From there, the esophagus starts. Okay, about 25 centimeter in length, begins at C6. It occupies here the superior mediastinum, below the posterior mediastinum. Okay, now you can see the aorta is lying to the left of it. Okay, or you can say the esophagus is in the middle, then it moves a little to the right, then it again comes to the left. So this is what we are seeing it from the left. So you can see the esophagus coming 1 and 2 times to the left, and here where it is arched by the arch of aorta, it is going more towards the right. So you can see the curve here of the esophagus. See the esophagus, not the trachea there. There are some constrictions of the esophagus. 1, 2, 3, 4, 4 constriction. First one here. How many centimeters? 16 centimeters from the incisor tooth. Incisor tooth. 16 centimeter at the part where there is the inferior constrictor. Okay, at the pharyngoesophageal junction, where it starts, there is a constriction because of the inferior constrictor muscle. How many centimeters? 16 centimeters. Then another constriction at around T4 level, where it is crossed by the aortic arch. Okay, about 23 centimeters. A little down, about 25 centimeters, there is another constriction because of the left bronchus. The left bronchus going like that. So it is actually, the trachea is not coming exactly in the center. The picture thoda sa gadbad hai. The trachea should be a little to the right. So only the left bronchus is coming like that. Okay, the left bronchus is coming like that, causing an indentation or constriction which is about 25 centimeter. Okay, at the level of T6. The last constriction is this, where it enters the esophagus, the stomach through the esophageal opening in the diaphragm. That is about the level of 10. So this will be the last constriction. Okay, about 40 to 38 centimeters, 38 to 40 centimeters. Now we are calculating it from the incisor teeth. As a whole, the length is 25. Okay, we are just seeing it distance from the incisor teeth. Now why this is important? Why this is important? While inserting a tube inside the esophagus, the Ryle's tube, when you insert it inside the esophagus, you should be knowing about the different constrictions of the esophagus. Okay, 16 or 15 in some books, 23, the second one due to aortic arch, 25, the third one due to the left bronchus, and 38 to 40 where it enters the stomach, where it continues as the stomach through the opening in the diaphragm. Relations in the neck. Anteriorly, you can see the trachea and a recurrent laryngeal nerve on either sides, which we have already discussed. Posteriorly, you can see the cervical vertebra. Here you can see the cervical vertebra in the neck and the muscle which is known as longus colli. On the sides, common carotids. See, this is the esophagus. One common carotid, yahan pe dusra, this is the esophagus, these are the common carotids. Okay, these are the common carotids. And the lateral lobe of thyroid. This is from the posterior aspect. So lateral lobe of thyroid on either side of esophagus with the common carotids. These are the lateral relations. Okay. In the thorax, anteriorly there is same, the trachea, the left bronchus, okay, the aortic arch, okay, the fibrous pericardium. So this, the heart only, this is not only the heart, but there will lie the fibrous pericardium over it. So ये हो गया esophagus, ठीक है, आगे हो गया trachea, left bronchus and the fibrous pericardium being separated by the esophagus through the oblique sinus. You can see the impressions of the esophagus here. This is the oblique sinus. Okay, and what? The posterior sloping, posterior sloping surface of the diaphragm. So trachea, left bronchus, okay, pericardium, okay, the aortic arch, the arch of aorta, and the diaphragmatic surface. These are the anterior relations of the esophagus in the thorax. What are the posterior relations? The thoracic vertebra, there is one, okay, with the intravertebral disc in between. Okay, This thoracic vertebra is lined, उसके ऊपर है anterior longitudinal ligament. Okay, then there are some veins which are known as azygous vein and termination of hemiazygous vein, which we have already seen here. Azygous vein, okay, and on that side termination of hemiazygous vein. It's not seen here. This one is the hemiazygous vein. So these are the posterior relation of the esophagus. Okay, then thoracic duct. You can see this one. There is a duct which is draining the lymph node, which is draining the lymph and opening interjunction here. So this is the thoracic duct. Okay, and the descending thoracic aorta. So as we have seen in the earlier picture, the descending thoracic aorta will go posterior to the esophagus. It is going posterior to the esophagus. Okay, so these are the posterior relations of the esophagus. Okay, if we see the structure, there is a fibrous coat outside, not shown over here, the fibrous coat outside with the areolar tissue and some elastic fibers. Then there are muscles which are running longitudinally, this is known as the outer longitudinal and inner circular layer. Okay, in the upper 1/3, the muscles are voluntary, middle 1/3 it is mixed, lower 1/3 it is involuntary. Then it gets continuous with the stomach. Okay, and another coat, there is the submucous coat and the mucous coat. What is the lining? What is the lining of the esophagus for the mucous coat? The arterial supply is by the esophageal branch of the inferior thyroid artery. Okay, branches from the bronchial artery. Okay, and some branches from the aortic arteries, plus some branches from the left gastric artery. The venous drainage is by the, you can see over here, this is the esophagus, these are the azygous and hemiazygous veins. So venous drainage by the azygous and the hemiazygous veins. Okay, and some part of this is known as this one is the left gastric vein. This is the left gastric vein. So there is an anastomosis. This left gastric vein is a part of portal vein, and the hemiazygous and azygous vein is a part of systemic vein. These two veins communicate here, and when there is portal hypertension, this is the left gastric vein which is giving some branch to the esophagus. These are the hemiazygous and azygous veins which are giving some branch over here. Now when these two are draining the esophagus, now once this portal vein is coming through the liver, when there is cirrhosis of liver, the pressure of this vein increases, which creates an alternate passage, okay, for the blood to get routed in other way so that it goes to the hemiazygous vein. So there are swellings in the area where there is enlargement of these veins, and this condition is known as the esophageal varices. Okay, through endoscopy you can see a varix, the enlarged vein like this, and then you have to clip or ligate it. Okay, you must have heard about the people who are taking alcohol, having cirrhosis of liver, they are vomiting blood, that is known as hematemesis, and that is due to these enlarged veins which are known as esophageal varices, which rupture and bleed. Another condition is there where there is a neuromuscular incoordination of the esophagus. This is the barium enema, the barium swallow, which is dye which is ingested, and a picture is taken to see the condition of the esophagus. Now you can see the dye is not going down. Okay, there is an area where the dye is just getting blocked, and this area identifies a condition which is known as the achalasia cardia, where there is neuromuscular incoordination of the muscles of the esophagus. Okay, so these are the two clinical anatomy of the esophagus. Lastly, the thymus. Anterior relations in the thoracic as well as the cervical part of the trachea lies in front of the subclavian, the brachiocephalic vein. It is a primary lymphoid organ responsible for formation of T cell, recruitment of T cell. Okay, and it is a double lobe, it is bilobe, encapsulated. Okay, the capsule may be adherent to the pericardium here. It lies in the superior as well as the anterior mediastinum. It is large in puberty. Later on, there is fibrofatty degeneration, and it may reach up to the fourth costal cartilage. Regarding the histology of the thymus, we will be having a separate class for that. So I think the time is done. Thank you. If there are any doubts, you can ask me in my WhatsApp. Thank you. Bye bye.